I'm interested in studying diseases that are relevant to me. So, as I said, I'd gone into malaria to begin with because malaria was a disease that I was very familiar with in my own family. It's the same with scabies. So when a job opportunity actually came up in the scabies and malaria at that time laboratory, I moved into the space. And at that time, they were actually moving away from malaria research. So by cosmetic, natural elements, so to speak, but it's just sheer luck, I'd almost say, I actually fell into scabies research. And I have been there for 11 years now. So it's a disease that when I'm discussing it with people who aren't familiar with the disease, and surprisingly, I think most people would actually be surprised to know that a lot of people have actually already know somebody who's had scabies. So a lot of people are familiar with the disease. But for people who aren't familiar with it, I always use the analogy of it's like having head lice. It's highly contagious. It's a very horrible, itchy disease to have. It makes life terribly uncomfortable. There's a lot of sleep deprivation that's usually associated because of the itch. It's a disease that predominantly affects children, usually in the first 2 years of life, with most children who do get scabies, particularly in Indigenous communities in the remote parts of Australia. Most of those children, those infants are having their first case of scabies within the first 2 months of life. It's so common as well in these communities, unfortunately, that it's become quite normalised. So people just live with scabies, which I just find a horrifying prospect. I mean, I would never ask anybody, as I say, I use the analogy of scabies, as head lice. Would you be happy to just live with head lice, or just become common in your household and it's just something we get and we just live with it? No, we wouldn't. It's the same with scabies, and I don't think anybody should have to tolerate that. So I had the opportunity to make a contribution to the knowledge around preventing scabies or treating scabies, and that's where I'm at right now, and I'm quite happy doing it. I'm finding it really enjoyable work, very fascinating work, and I feel like I'm actually contributing something to the knowledge system, but back to my community as well. So scabies is caused by a parasitic mite. It burrows, so it gets onto the skin, it burrows underneath just the top layers of the skin, and that's where it sets up house basically to lay its eggs, to mate and to lay its eggs. Patients there are two types. There's ordinary scabies, and this is when you might just have maybe a dozen, 20, 30 mites that are residing usually in the nice, warm, moist parts of your body. So in between here, groin area, around here, behind the ears, behind the backs of the legs. So those nice places where you get lots of nice, warm, sweaty bits. So the mites will get in there and they'll set up an allergic reaction. So there's itch that comes. I've been told that the itch is worse at night. And that's why a lot of people have sleep problems, because they can't sleep because of the itch being so bad. Unfortunately, a lot of people who, as you say, like if you've had a mozzie bite before or any kind of bite, you start scratching. And once you start scratching, you're breaking the skin quite a lot. And any bacteria that is in the local area or under your fingernails or that's quite opportunistically surrounding you can get into that broken skin. And so secondary bacterial infections are established. So people get this terrible itch. They're not sleeping very well. They're very uncomfortable. They're becoming irritable. Can you imagine this in children under 2? So they're making life miserable for everybody. Then those scratches become infected with bacteria. So now you've got skin sores as well. And that's usually the first time that people will actually approach a doctor, is because they've actually got these oozing sores or very, very itchy sores and they need something sorted out. So unfortunately with scabies, there's a high rate of misdiagnosis. People think doctors who aren't familiar with the disease anyway, will usually diagnose the bacterial infection first, clear it up with an antibiotic of some sort. But the underlying parasitic infection is usually not resolved. So it's highly contagious. So you can have the infection for about 2 weeks before you start to feel the itch. In that time, you've probably had contact with a lot of people, so you've probably passed the mite on to other people as well at the same time. So yeah, it's an uncomfortable disease to live with, and I personally would not want to be living with it every day.
Uncomfortable sounds intolerable. Like no one should have to tolerate that. I mean, there's research that showed that 70% of Northern Territory Aboriginal infants are infected before their first birthday.
Yeah.
So, I mean, I can't comprehend how anyone, and especially a young child, should have to put up with that. Why is it so prevalent in Indigenous communities?
I would probably put it down to the most common feature being overcrowding. A lot of people, like with head lice, assume there's an issue with hygiene, cleanliness. It's actually got nothing to do with hygiene at all. It's quite prevalent in communities that live along the coastline. So children are bathing in the ocean all the time. So it's not about cleanliness. It's about opportunity, essentially. It's a highly contagious disease. So it only takes one person to have it. Once you have it, it's very easy to spread. But like head lice as well, if only one person in the household has it, everybody in the household has to be treated. So you've got highly contagious, you've got everybody in the household must be treated. The treatment is a really horrible treatment as well. It's a cream, it's very sticky, it's a very cloggy sort of sticky ointment that you have to put on. You have to cover yourself from head to toe and you have to leave it on for 24 hours, then wash and then repeat. So if you've got a household with lots of people in it, everybody needs to go through that process twice. And all the bedding and the linen and all the couches and that sort of thing need to be washed and disinfected as well. So overcrowding is probably the biggest problem, which is contributing to the contagiousness. Although there's limited experimental data that support it, what we do have is a lot of clinical data. So that is data from clinicians and from GPs that clearly state that a lot of patients who come to them with underlying diagnosis of scabies, so when that's correctly diagnosed, also have bacterial infections in those skin sores that I was describing earlier. Unfortunately, a lot of the bacteria that is associated with scabies skin sores are also associated with the development of chronic diseases such as rheumatic fever and rheumatic heart disease and downstream chronic kidney diseases. So if untreated, it's also intolerable, but you're going to have reinfections and more opportunities for more bacterial infections and a greater opportunity for there to be the development of these diseases that start to impact essentially on your lifespan and the quality of your life. We see scabies as a gateway disease. It's a horrible, intolerable disease. We don't think people should have to live with it. But as we say, we see it as a gateway disease. If we're able to close the gate on the mite, we see it that we're potentially closing the gate on these associated pathogenic bacteria as well. So by improving the quality of life by reducing scabies, hopefully that has the downstream effect of also improving the quality of life of reducing the amount of rheumatic fever, rheumatic heart disease, and chronic kidney disease. If you look at the statistics alone, in areas, particularly in Australia, where scabies is endemic, the highest rates of rheumatic fever and rheumatic heart disease also occur. And unfortunately, the highest rates of rheumatic fever and heart disease in the world are actually occurring in Australia in those communities. We're hoping, as I said, that by treating scabies, we actually have a downstream effect on these other chronic diseases. It's a common problem. Much like head lice, it's everywhere. It doesn't discriminate in any way or any shape and form. It's a global disease. I believe the World Health Organization has numbers around about 300 million cases globally occurring around the world. The exact numbers on scabies prevalence in Australia are actually unknown. We do believe it's a highly unreported disease. It's a disease that does not have to be reported, so there is no surveillance system. So we have no true statistical numbers about what's occurring. All we have is anecdotal, if you want to put it that way, empirical data that comes in from GPs and clinical. But it's highly common. So you'll get it, yes, very badly in remote communities which have overcrowding and usually poor access to health systems or health support systems. But you will just as likely get outbreaks. And all you have to do is a Google search on scabies outbreak, say Australia, and you'll get a number of stories across the internet of outbreaks in high schools, primary schools, childcare centres, aged care facilities, jails, refugee places where people are being contained in areas in close quarters for long periods of time. Nurses quite regularly get cases of scabies from patients, and they're passing it on unwittingly onto other patients. So that's why it can be quite contagious or quite prevalent in aged care facilities where patients are sometimes immobilised or lacking mobility, so they might not feel the itch for quite a prolonged period of time, and the bite burden is growing, and so they're able to pass the disease on. So yes, it's not limited to Australia. It's not limited to poor or socioeconomically challenged communities. It is common. It can be found anywhere, both in Australia and around the world. We are hopeful. I mean, you can only ever have hope that what you're doing is contributing certainly to the knowledge base that will allow other researchers or yourself to progress forward faster. Everything takes time, unfortunately, and finding an answer or a cure or a breakthrough in the laboratory space is only the first step. Once we have that information, being able to move it into a space or into a vehicle where it's actually able to be made into a therapeutic, again, takes its own amount of time. I wish it went faster. If we had lots more people working on it, perhaps it would. If we had if it all changed tomorrow because of a major breakthrough, that would be fantastic. And I think that's every researcher's goal and dream, is to be able to crack crack the answer and to move forward faster. But that's the reason why we do what we do. We're trying to contribute information and knowledge to the knowledge base so that if we're not the ones who discover the breakthrough, somebody else is. It's not about us, it's about generating knowledge pools. So somebody has a breakthrough to get things across the line, so to speak. It's all contributing to this massive knowledge base. We are all in it for one reason, to basically help people. So I'm hopeful that we're moving closer towards that. It would be nice to say we should have a drug within the next couple of years, but these things take time, but we're working on it.